First of all, I know you're a mixed audience, mainly of clinicians, but also a few microbiologists, so I'm going to speak a little bit about microbiology, but quite a lot about clinical use of antibiotics. What makes ITU different? Well, our patients don't talk to us. That's one major thing. Very difficult to make the diagnosis. And also, particularly when you're thinking about ventilator-associated pneumonia, inflammation mimics infections. Very difficult diagnosis to make, as we all know. Furthermore, you get multiple sites of injury in the intensive care unit. You may have trauma, you may have other medical conditions complicating the presentation of the patient. And finally, you have multiple mechanisms of injury. You may see DIC following on from a bacteremia or a septicemia as an organism that's arising, shall we say, from a local abscess in the abdomen. There are other reasons why intensive care is different as well. There's issues of the skin integrity. We penetrate the skin of ITU patients and provide superhighways for bacteria to get into those patients, be they through central lines, catheters or stomas. And then, what's a normal ITU patient physiologically? Well, if they've got a hemoglobin above 7 and a saturation above 92%, my ITU therapists, if it's a seriously ill patient, are pretty happy. So normal is relative. And finally, most importantly, there are issues of immunosuppression. The patient may be specifically immunosuppressed, but immunoparesis is also a very important concept in the intensive care unit, and it's very poorly understood generally. And that's one of the reasons why intensive care medicine is difficult as well, because whilst we may have the benefit of huge numbers of patients in trials for statins or even for antimicrobials more generally, in the intensive care unit we're very much restricted in the patient base that we have to make our evidence judgments on. Studies are often small numbers of patients, tens of patients. Occasionally they may be hundreds. And then on top of that, you have the impact of multiple organ dysfunction. We're not dealing with a fairly normal surgical patient with sepsis here. We're dealing with patients that have already had major organ failure. And you're giving a whole range of drugs which may interact with the antibiotics or interact with the infection. It's a very complex picture. I think it's one of the most challenging and interesting aspects of clinical microbiology. And when I'm doing clinical, I very frequently do the ITU ward rounds. We do a daily ward round, ITU ward round in my hospital as microbiologists. And there are 4 aspects which are key to understanding therapy and management of patients in ITU. And I've put them in at the bottom there. First of all, the fundamental importance of early treatment. I'll show you a little bit of data about how key that is. How long do we give antibiotics for? Again, not easy in the intensive care setup. Patients may be mimic infection because they've got inflammation. When do we use combinations? Not just necessarily fixed drug combinations, but frequently in the ITU we may use vancomycin in combination with, say, a carbapenem. When is that appropriate? How long should we use them for? And finally, what I'm going to talk a lot about is what do we do if we've got multi-resistant pathogens? But at the end of the day, it's a very satisfying and intellectually demanding aspect, managing infection in the ITU, but it is basically veterinary medicine. We are just vets in that setting, I think, sometimes. And that's where your clinical skill and understanding becomes very important, and experience.